Now, Douglas Weaver is joined by Dr. David Woods, the Garfield Weston Professor of Medicine at the International Centre for Circulatory Health and Lung Institute at the Imperial College in London, UK, to discuss principles of cardiovascular disease risk prediction.
Welcome to ACCEL.
Thank you.
Tell me about risk prediction for the prevention of cardiovascular disease.
So risk prediction is absolutely central to primary prevention of cardiovascular disease because it gives you the big picture. So when you see a patient who does not have vascular disease but might be at high risk because of raised blood pressure or dyslipidemia, it's important to measure all of the risk factors and to estimate total cardiovascular risk, in other words, the probability of developing cardiovascular disease over a defined period of time, usually 10 years, and then to manage them accordingly, to manage them in the context of that risk assessment.
Right, and we're talking about primary prevention. This is picking up people who are at risk for developing cardiovascular disease in the future, not secondary prevention. And I think of all the things that are being measured by primary care physicians and cardiologists in my country, which includes patient satisfaction. It may include how well are you doing your diabetes therapies and examinations, but I don't think people are routinely calculating risk on any of these individuals. Should they be?
I think that's true, and it's not just true for the United States, it's also true for many parts of Europe. And I think that's a consequence of the silo mentality towards cardiovascular risk. In other words, instead of looking at blood pressure in the context of total cardiovascular risk, the physician instead diagnoses whether or not the patient has hypertension. Mm-hmm. But actually, the contribution of blood pressure to the subsequent development of cardiovascular disease is dependent upon the company it keeps, and a blood pressure level of 140 millimeters of mercury in a smoker who is dyslipidemic confers a much higher risk than a blood pressure of 140 millimeters of mercury in a lifelong non-smoker who is thin and has normal lipid levels. So we really need to move away from looking at risk factors individually and to look at them collectively and to estimate the probability of developing cardiovascular disease.
So one of your principles obviously put forward here is looking at the entire patient and what the risk is. How do we get this implemented into practice? Why hasn't this happened?
Well, in my country, it has. So in the United Kingdom, the Department of Health introduced a health checks policy.
Okay.
And they required general practitioners to offer a health check to all adults between the ages of 40 and 70 years. And that health check included an estimation of their total risk of developing cardiovascular disease. It also included an assessment for diabetes and for chronic kidney disease as well. And that has really transformed the approach to primary prevention in my country. But it requires a national policy.
And what was the incentive for physicians to do this?
So the incentive was that the physicians were rewarded on the basis of points earned for quality of care given. One of those areas for which points could be earned was risk assessment, and then as a consequence of finding people at high risk, in managing them effectively.
Excellent. And what are the limitations?
I think one of the most important limitations is that in order to accumulate sufficient risk to a level at which you will be prepared to use drug therapies to lower blood pressure or modify lipids, requires exposure over many years. So you don't usually reach the risk threshold, which would be, in my country, a 20% risk for non-fatal and fatal cardiovascular disease combined over 10 years. You're not likely to reach that risk threshold until you're in your 50s or 60s. Mm-hmm. And for women, it's even older. And that means that many younger people, regardless of their level of risk factors, simply don't reach the bar.
Right.
And that is a problem because it means that younger people who have unhealthy lifestyles and those lifestyles are impacting upon their blood pressure and their lipid profile will not receive treatment and indeed may succumb to the disease before they can even pass the threshold where treatment would normally be given.
Right.
So that means that treatment is concentrated in the older and elderly population.
Right.
And one way of addressing this problem is not to look at total cardiovascular risk, but to look at heart age.
Okay.
So you measure all of these risk factors and you say, what's your chronological age? Well, I'm 43 years old. Well, actually, based on this risk factor profile, you have a heart age of 57.
Mm-hmm.
And this is being developed as a risk tool for my country.
Mm-hmm.
And the expectation is that this will be more readily understood by patients than a probability estimate and may motivate them in a way that a probability estimate does not, because thinking about your heart as being many years older than you actually are might be quite a big incentive to do something about your lifestyle.
Right. And I would imagine in your formalized program in which physicians do risk assessment, they share this with patients, but it doesn't really mean a lot to them. Is that right? And so by tying this to, well, this means that your heart age is 15 years older than what you are, maybe you will listen and will change your lifestyle a bit.
Yes, and actually all of these tools come in electronic versions. So
excellent.
Even if you're estimating total cardiovascular risk and you say, well, your risk of developing cardiovascular disease over the next 10 years is 24%, so you have about a 1 in 4 chance of this happening, you can then show them electronically what happens if they stop smoking, if blood pressure is reduced to the target level, if their lipids are managed appropriately. You can actually show how their probability of developing cardiovascular disease falls. And you can do the same with the heart age tool as you demonstrate to them the consequences of stopping smoking and how the heart age drops and comes closer to the person's true chronological age.
I like that. So it's interactive. You can do this on a website.
Yeah, you can do this in front of the patient at your desk.
Excellent. And are people doing this now?
And people are doing this now. With the probability risk estimation tool, that's widely available in software form. The heart age is only coming onto the street now.
Okay.
And I think the most readily accessible version at the moment can be taken from the New Zealand Heart Foundation website, where they are actively promoting heart age as a way of assessing the population for primary prevention.
Well, I think we must be way behind in our country then, because we're very siloed right now, and taking this much larger approach seems wise. What do you see in the future? What do we need from a research standpoint, and what do we need in order to... This kind of prevention is going to make a huge difference to people, as well as the cost of health in all of our countries.
But that's the critical question, actually. The critical research question is that if you estimate cardiovascular risk by whatever method, and you inform the person about their cardiovascular risk, what impact does that have in terms of their ability to change their lifestyle and the physician's attitude towards managing their other risk factors such as blood pressure and lipids. And at the moment, we don't have good randomized controlled trial evidence that the application of these tools in clinical practice
actually
changes behavior and risk factor management. And I think that's the next important step.
Well, this has been a fascinating discussion, Professor Wood, and I really appreciate you sharing it with us. I've learned a lot today, and I'm sure the ACCEL audience has as well. Thanks again.
My pleasure. Thank you.